reverting to the original program. Abra Hussain.
Hi, good evening everyone. I am Abra Hussain. I am a consultant in Liaison Psychiatry, and it's a bit unexpected because it spoils my mental ritual. I was planning Eric to go next. But anyway, I want to start with a little anecdote. 4 weeks ago, I was training a group of psychiatrists, junior psychiatrists, and they were appearing for the membership exam in psychiatry. It's an OSCE-based exam with stations and role players playing different clinical conditions. And the station was on medically unexplained symptoms. And there was a very challenging actor who was asking all sorts of difficult questions. And when he asked the question, "So doctor, is this physical or psychological?" The doctor said, "All conditions are both." So I thought the 4 words that actually beautifully summed up this interface between physical and mental health. So with that, so in terms of an overview, I'm going to start off with MUS and LTCs, why we should take them seriously, why we should treat them, a little bit about publications, the gap in the community where Liaison Psychiatry can have a role, and finally the pathways in Berkshire. So MUS is important because it causes real distress, they are real symptoms, and we have interventions that are effective. So we treat them. And unfortunately, a small group of patients start making frequent contact with the healthcare system, acute hospitals and primary care, and that costs a lot of money. The biggest challenge is trying to get the right terminology, the right name for MUS. And this is the challenge. And if this wasn't enough, then because we are so well organized in the provision of care in hospitals, each department has its own way of describing what MUS is. And this doesn't help us when we try and pin down the symptoms and try and offer treatment. So last year when we set up a project for MUS with GPs, we sent out electronic newsletters on a monthly basis, and we deliberately named it Medically Explained to actually give a visual message that if you really looked hard, you would find a reason, you would find options to treat. This is a project we did in collaboration with the University of Bristol, and in this very room 6 months ago, we won a prize for this poster. Actually, it's displayed in the foyer upstairs. We found that patients, this was actually a survey of the general public, so not patients per se, but they were happy to seek treatment and engage treatment, but didn't want to be seen as being referred to psychology or psychiatry. So I think we need to do something innovative around what we call the treatment, or what we call the service. It costs money, directly £3 billion and indirectly £18 billion. LTCs, again, the big problem. We know about the overlap between LTCs and mental health problems. 1/3 of patients with LTCs have a mental health problem, and about half of those with mental health problem have an LTC. And as the number of LTCs goes up increasing, the cost to the healthcare system again increases. It's estimated that by 2020 there will be a further 30% increase in LTCs. And this is where I come in. So I have a slight slant towards community liaison psychiatry because I'm based in the community. And failing to deal with MUS and LTCs costs money, costs poorer healthcare outcomes. And it is now thought of as a well-established service might be more in the community, working in collaboration with the hospital liaison service. Luke has also already mentioned this. A typical liaison psychiatry service in hospitals can save up to £5 million a year. And so both clinically and economically, I think the case has been made. But what I'm really interested in is this extension of liaison into the community, setting up clinics with GPs, with hospital departments, looking after MUS, LTC, and self-harm. And in long term, this might be how the care is delivered. I see lots of patients in primary care who have frequent appointments with different departments for MUS, for LTC, who unfortunately fall in this gap because they don't really meet criteria for mental health teams, for secondary care mental health. They won't go and see a psychologist, either in IAPT or health psychology, and it's left with GPs and community services to actually manage these patients. So this is an area where I think the extension of liaison from hospital to community can also play a big role. I'm going to now move on to the pathways in Berkshire that have been set up in the last year or so. I've been in post for about 14, 15 months now. And Berkshire is slightly unique because it's thin and long along the M4, as you would know. And it's got 7 CCGs and 6 localities and 2 acute hospitals. I've said Frimley Park because about 10% of A&E attendance in Frimley Park is actually Berkshire population. But the good thing is there's only one single point of entry called the CPE for GP referrals. So I've been able to do some work with CPE in trying to set up a specialist liaison psychiatry assessment service and seeing patients with physical symptoms and psychological comorbidity. Again, signposting them, making formulation, giving an impression, making a joint plan with the GPs, that's been very helpful, and very occasionally having a caseload and following them up in primary care. Second service that is set up in the last year or so is the MUS project for frequent attenders. So this is an IAPT Pathfinder project, and Berkshire is a Pathfinder site. The biggest positive for me is joint working at step 4 with health psychology, and Alison is here from health psychology. Providing that specialist assessment at the very beginning from 2 different disciplines has been really important, and also obviously upskilling GPs, working with IAPT has been really helpful. So in second year we are now going to recruit more patients, slight modification to the care pathway, Alison in the lead, and my role is going to slightly change from just being at step 4. I'm going to now start providing input into all stages because that's probably a more practical way of helping patients. Third is the East Berkshire initiative. Angela Jones is going to be speaking as well after me, I think. And this is a specialist clinic set up with the respiratory medicine department in King Edward VII Hospital. And this provides a weekly assessment service, joint working, signposting, and treatment. And just to give a flavor of the feedback that we've had, there's a patient who had difficult to control asthma, who was smoking, and just that initial session where we put the formulation in place, try to understand why she was smoking a lot, seemed to help her to try and cut down smoking, which helped her physical health. And last but not the least is the West Berkshire initiative with neurology. And this is a weekly clinic again, providing assessment service, providing treatment and joint working. And recently we had a case conference where we had the patient, the carer, neurology, physiotherapy, and liaison psychiatry trying to work together and form a joint care plan. And again, this is a flavor of the kind of feedback we've had. This patient, for this patient, the maintaining factor seemed to be that she thought the non-epileptic attacks were actually being seen as faking an attack. So actually just understanding that this is a diagnosis of functional illness seemed to help her. So where are we now? So overall then, work in progress, still work to do. There's lots of other departments and initiatives that we need to work collaboratively with. In the East, the cardiology setup was to try and work with clinical nurse specialists, to try and manage non-cardiac chest pain. We need to do a bit of work around recruiting more patients. In the West, the pain initiative seems to be promising. Again, we need to do a bit of work and also have a bit more resource to try and develop these initiatives. And finally, to use an innovative approach to MUS and LTCs, it not only saves money, it also improves quality of life, having a collaborative approach in the community, providing holistic assessments. And I'll end with those 4 words which I started with. All conditions are both, because I think they beautifully sum up what this is all about. So thank you very much.